I know I work at MD Anderson now, but I spent my residency, fellowship in the county hospital system, and there's a big disparity in terms of access to care and outcomes. So in AML, the standard of treatment is 7+3. This has been around for over 40 years, and outcomes aren't the best, but a lot of the community practices and non-academic healthcare settings are still using this in younger fit patients. It does result in a little bit more inferior survival than we've seen in more intensive therapies and also in older patients. So the treatment of AML and leukemias in general are molecularly based. So the presence of a mutation would actually dictate differences in treatment. For example, with FLT3 mutations, you would get a FLT3 inhibitor, IDH1/2, same thing. And now there's a new class of drugs called menin inhibitors for NPM1 mutated patients and MLL rearranged patients. Now, there's disparities in terms of the access to this testing. So some of the more underserved or underrepresented communities are not able to do these molecular testings. And even in the county hospital system or a population where they can do the testing, it does take quite some time for it to result. So we have seen a lot of cases where patients, they receive frontline therapies assuming they do not have these mutations or targetable molecular aberrations, but then it results later and they have to switch therapies. So a lot of the academic healthcare settings or the big cancer centers who are represented at this conference, we have clinical trials where we test more novel combinations or more intense combinations than patients can get off of a clinical trial. So a lot of times just a patient in an urban area has more access to care than someone in a rural area. And also depends on your proximity to these cancer centers. And this has been demonstrated across the United States. I would say the field is moving, but a little bit slowly. So there's a lot of collaborative efforts between institutions on addressing these disparities. We can start by increasing clinical trial enrollment with underrepresented patients. So at MD Anderson, we've been trying to open a lot of our trials in the county hospital system to account for this. There have also been a lot of collaborative efforts looking at different inclusion and exclusion criteria for just for the clinical trials. So for example, I know like Dr. Hantel at Dana-Farber, he's been looking at Delphi null phenotypes and trying to not exclude patients based on that. And that is predominantly in a Black setting. So there have been efforts, though it is moving slowly and a lot of work still needs to be done. One is that a lot of the kind of the genetics or genomics of the disease are based on predominantly white populations out of Europe. So a lot of the questions are, do underrepresented patients still have the same genetic aberrations? We don't fully know that. The other thing is, do treatment differ based on racial or ethnic disparities? We also do not know. So a lot of our guidelines are based kind of a blanket guideline regardless of race. So still some work needs to be done.